We're going to go on to our third abstract, and this one is by Dr. Ananya Sharma at the All India Institute of Medical Sciences. And again, I have visited this institute many times, and always exciting to visit the All India Institute of Medical Sciences in New Delhi, or AIMS. And in AIMS, they have another group of very enthusiastic researchers and a great center for studying both medical and surgical aspects of vitiligo, as well as basic research. So today we're going to hear from Dr. Sharma, who will be talking about dermoscopic features of vitiligo and hypopigmented skin lesions other than vitiligo in Indian patients.
A very good morning to all of you. I'm Dr. Ananya Sharma from the Department of Dermatology in AIMS New Delhi, and I will be presenting today about dermoscopic features of vitiligo and hypopigmented skin lesions other than vitiligo in Indian patients. So we know that when a dark-skinned patient has a light lesion, it presents with quite a significant skin contrast, and this leads to the lesion being obvious. This leads to a lot of social stigma in these countries, and furthermore, it can be compounded if there is a lack of a definitive diagnosis about a hypopigmented lesion. So in our study, we aim to study the dermoscopic features of these hypopigmented skin lesions, as well as to utilize the dermoscope as a tool to differentiate between different entities which present similarly. We also looked at the dermoscopic features of vitiligo lesions as per activity to see whether they were progressive or non-progressive and whether this could be decided on dermoscopy itself. This was a cross-sectional descriptive study conducted in the Indian Institute of Medical Sciences, New Delhi, over a period of 1.5 years. So we included all patients with a confirmed diagnosis of these entities as listed, and some of the entities had a clinical diagnosis which were concurred upon by two different dermatologists, and the others had a clinical as well as an investigational basis. Dermoscopy was done using a DL3, mostly used in the contact mode with the polarized mode, and sometimes the non-polarized mode was used for seeing the surface changes. We excluded those lesions if the diagnosis was in doubt or if there was any secondary change over the lesion. Also, we defined the activity of vitiligo lesions using this criteria that if a lesion had appeared more than 3 months back and had not changed in size since then, it was considered stable. If it had appeared more than 3 months back but had decreased in size, it was considered repigmenting. If it had increased in size further, it was considered progressive. And if it was a new lesion which had appeared within the past 3 months, it was considered as a progressive lesion again. I'll be describing my results in three different parts. The first being the dermatoscopy of vitiligo and comparison by activity. So we had a total of 105 lesions of vitiligo, and for the purpose of clinically meaningful analysis, we decided to combine the stable and depigmenting lesions together to form a non-progressive group, which now had 66 lesions in this group, and progressive being 39 lesions. So we'll be describing the dermoscopy findings under these headings. So in the margins, the most common margin seen was that of intermediate definition. However, we saw that if we saw ill-defined margins, the lesion was more likely to be progressive in nature, which is similar to what we see clinically. Coming to the pigment network distribution, either classified as complete absence of pigment network, complete presence of pigment network, a partially present pigment network, a peripherally present pigment network with a central absence, or a pigment network which was almost completely present with a focal loss of pigment network. So in this, we saw that most commonly in vitiligo, there was a complete absence of pigment network seen in 2/3 of the lesions. And also, this was more likely to be seen in non-progressive vitiligo, although the difference was not statistically significant. In the pigment network type, we classified this as normal pigment network when the intensity of the pigment network within the lesion was similar to that of the surrounding skin, and it was classified as faint if the intensity was lesser than that of the surrounding skin. Further, we also saw inverse as well as atypical pigment network, which is classically described in literature as can be seen highlighted in these images. So for the pigment network type, the most common pigment network in vitiligo overall was faint pigment network, and this was much more likely to be seen in progressive lesions. Coming to the background color, all the lesions were most commonly depigmented, and this was uniform between the groups. And the perifollicular changes, however, were quite different. So if we saw pigment retention, the lesion was more likely to be non-progressive. So this was quite specific with 80.6% specificity. Now, perilesional changes were classified as follows: that it could either be hyperpigmented, could be hypopigmented, or we could have perilesionally white dots. And this is classically described in literature as the polka dot appearance. So in this perilesional changes, we saw that when there is perilesional hyperpigmentation, it is more likely to be a non-progressive lesion. And when there is perilesional white globules, the polka dot appearance classically described for progressive lesions. Leukotrichia was more often seen in non-progressive lesions, and similarly vasculopattern. The other changes such as surface changes, erythema, structureless areas were not commonly seen in vitiligo. So to present to you a classical lesion of progressive vitiligo, we see that there is an ill-defined lesion with partially present pigment network. Here we can see at some places the pigment network is present, and we can also see that there are perilesionally white dots present which are marked by these red arrows. Whereas in a non-progressive lesion, there is a relatively intermediately defined lesion with perilesional hyperpigmentation as well as perifollicular pigment retention. So this is quite classical for a non-progressive lesion. Coming to my part 2, here we see that in non-vitiligo group, we had many different diagnoses of 14 entities comprising a total of 137 lesions. So to how to differentiate whether a lesion is vitiligo or non-vitiligo. So for that, we combined all the non-vitiligo groups together and compared them with vitiligo. Here we saw that a well-defined margin was more likely to be seen in a non-vitiligo lesion. In the pigment network distribution, a complete absence of pigment network we saw earlier was quite common in vitiligo. So if we see this feature, it makes a lesion 10 times more likely to be of vitiligo rather than of non-vitiligo. And the pigment network type when present, this was also statistically significantly different between the two groups, and a normal intensity pigment network was more commonly seen in the non-vitiligo group. The background color was depigmented commonly in vitiligo as expected, and in the perifollicular changes, it is important to see when we see perifollicular retention of pigment, the lesion is more likely to be that of vitiligo. In the perilesional changes, there was no significant difference, and leukotrichia, as expected, was more common in vitiligo. The vascular pattern changes. The lack of a vascular pattern can be seen as a pointer towards a non-vitiligo lesion. Also, eccrine openings were more easily discernible in non-vitiligo lesions compared to vitiligo, where often we are not able to appreciate them because of the depigmentation, which leads to loss of the outline of eccrine openings, which we normally see to identify them. Other changes such as scaling are also significantly more seen in non-vitiligo lesions, and vitiligo on the surface appears to be a bland lesion. So to summarize, we have certain features that the absence of pigment network, depigmentation, perifollicular retention of pigment are much more likely to be seen in a lesion which is that of vitiligo. So as we saw in the beginning, a patient who had a facial lesion of a hypopigmented lesion whose diagnosis was not clear in the beginning, once we do dermoscopy, we can see that there is scaling present, and we can say that scaling is much less likely to be seen in vitiligo, and this is a lesion that was of pityriasis alba. Thank you.
Thank you very much, Dr. Sharma. That was very interesting. There was a huge amount of information there that will take me a long time to digest and think about. And I look forward to seeing the paper so I can think about this. I look at patients every day with my dermatoscope with vitiligo to detect leukotrichia. But one question I have for you before we get on to the other questions is that it's sometimes difficult to tell if if the margin of the lesion is actually getting worse or getting better. Because as you know, sometimes when you treat vitiligo with phototherapy, the new pigment does not come back as the same color as their normal pigment. It comes back lighter. So in that situation, you look at it and say, is this trichrome vitiligo or hypochromic vitiligo getting worse? Or is this vitiligo getting better? And you described two things. One is pigment network and one is margins. So I'm a little confused by that. How can you tell if the margin and the pigment network is vitiligo getting better or vitiligo getting worse?
So yes, sir. So this was an issue that we faced in our study. So when we are looking at the pigment network, so we are looking at the reticulate pattern, which we identify as the pigment network. And then there is the background color of the skin, which can be depigmented or hypopigmented, or as you mentioned, after phototherapy, it can get hyperpigmented. So in a treated lesion, the issue which occurred was that where do we consider the margins of the lesion? Because if we consider it inside, so then we feel that the lesion has a perilesional hyperpigmentation. And if we consider it outside, so then the perilesional hyperpigmentation is not there. So that was an issue, which is why we ended up classifying these lesions as taking them as the background color. So, sir, I did not highlight that in my presentation, but which is why we had three backgrounds of depigmentation, hypopigmentation, and a trichrome pattern. So that trichrome pattern, we eventually classified it as a background pigmentation, and that is why, as is also I think being mentioned in the questions, that is why it came out as something which was more seen in non-progressive vitiligo, not like the trichrome we commonly see clinically as a marker of progressive vitiligo, because it also included lesions which had repigmented from the periphery, sir. So that is an issue which was not addressed, sir. We realized this at the end of the study.
Thank you. Thank you very much. Well, there are a couple more questions that you can answer on the chat. And if anybody else has questions for Dr. Sharma, you can ask on the chat. One thing that I would recommend that you do for our own benefit is patients are notoriously bad at telling you whether their vitiligo is active or not because of recall bias. So I recommend you follow these patients over time and you determine if they're worse or better, and then you do the dermoscopy based on physician confirmation that they're actually worse or better, so that we can watch dermoscopy over time. So I look forward to seeing more research from your center. Thank you, Dr. Sharma.